Good morning, everybody.
Great. Okay. Would you like to introduce a little bit the team and then to explain a little bit the case and what are you going to show us?
Yes. Yes, we are going to do a reablation of AF guided by MRI imaging. And is with us the Dr. Fernandez Armenta and David Andreu, that is our engineer. Yeah? Okay, this is the case for today. So as I told you, this is a reablation of AF guided by the MRI imaging. This is a 51-year-old man with lone AF since 2009. He was symptomatic on antiarrhythmic drugs, class 1. Left atrial diameter was 38 millimeters, not dilated, and the left atrial sphericity index was 78%. That means that it's a discoid left atrium, that there is no remodeling process because of AF. Next slide. This is the aspect of the left atrial body that we have surrounded by excluding the pulmonary veins and the left atrial appendage. So this is the discoid left atrial body. Next one. So in November 2012, there was an AF recurrence with frequent atrial fibrillation episodes. The patient became symptomatic despite the use of flecainide and is programmed now for a reablation procedure. Next one.
Antonio, we did the first ablation in our lab. And
yes.
What was done in the first ablation? Yeah.
This is a standard ablation, a pulmonary vein isolation without lines. Okay. So this is our standard approach for this kind of cases. We first of all obtain delay enhancement cardiac magnetic resonance. After that, we would do a post-processing of the image obtained. This is obtained with a 3 Tesla machine with a 3D acquisition. So when we have the image, we do a manual segmentation of the endocardium and epicardium of the left atrium with a self-developed software. And after that, we obtain a three-dimensional left atrial reconstruction with another software we have developed also here in Barcelona. And we obtain a pixel signal intensity map from the endocardium to the epicardium at the 25% of the layer, 55% and 75%. And we don't use usually the endocardial layer and the epicardial one to avoid confusion with the cavity and with the fat of the left atrium, surrounding the left atrium. And with that, we obtain.
The software, if I may interrupt you, the software really give you several layers of the atrium, and then you choose the best image that you had. Okay.
Okay. And we have finally a scar characterization with core and border zone. Okay, next one. This is the final aspect of the case of today. As you can observe here, it seems that there is an isolation or an early isolation of both inferior pulmonary veins, and that it seems that there are gaps in both superior pulmonary veins.
But it's interesting, I can say that when you imagine what is a line, and you think you do a line, and what that you have after PV isolation, you understand that it's not exactly a line, that when you try to isolate the posterior wall, you create a lot of lesion there. So the concept of line, it's very useful, but when you look at the result in MRI, it's really a more extensive lesion what you are creating indeed.
Can you explain to us what the color coding is here? So what does the red color reflect and the purple color reflect, and so how did you set the thresholds here?
Red color reflect the areas with the higher pixel signal intensity with gadolinium on the MRI, and the purple ones are those zones without gadolinium enhancement. So the standard cutoff values we use is 40 and 60% with slight modifications, because there are some variations.
So
sorry?
If I would ask you now, based on the experience that you have, just looking to this map, this MRI-based map, without putting a lasso catheter inside of the heart, would you like to speculate what you would expect to see if you put the lasso in the 4 pulmonary veins? Which vein would be isolated? Which vein would have conduction? which vein would have delay. Anything that you would like to share with us, what you would expect to see?
Usually, there is a high degree of concordance between the lesions we see. So we are looking at tissue lesions. So usually there is a high concordance. What happens in several cases is that you can have some discordance. So sometimes you can have no lesion and the vein is blocked. What we don't know exactly in this case is what we have to do. Probably we have to complete the tissular lesion because maybe the vein is not conducting at this time, at the time of the AF ablation, but maybe the vein can conduct in several modes or later on after the ablation procedure. So this is what are we investigating now. But usually there is a high degree of concordance. We are looking at that today in this case.
Okay, please go ahead and show us what have you done so far.
First of all, I want to show you, because we have done a high density map of voltage map of the left atrium. David, can you show? So this is the voltage map we have obtained. So it's a high density, but not too much. There is, as you can see, a high degree of concordance between the tissue lesions we have identified with the MRI and the voltage map we have obtained on the left atrium.
So you have on the left, you have the MRI, and on the right, you have the voltage map, isn't it? The Caso signal, okay?
Yeah,
so
right.
If you see that there's really quite a concordant according to the voltage map here and here, so it seems that really it's quite correspondent.
Before starting burning, we can take a look to the MRI. David, do you want to show the MRI exclusively in the screen? Okay, so look at the left inferior pulmonary vein. So it seems that there is a gap on the lateral aspect of the pulmonary vein. We have tagged with a dot. And if we continue looking at the left-sided pulmonary veins, it seems that there is a more or less big gap on the left superior. That is what we usually see after radiofrequency ablation.
The appendage is covering that. Can you rotate a little bit that?
Yeah, please.
Because
can you
show us
can
the
you rotate
upper,
a little bit
left,
more?
Yes, the left upper we want to show you.
This is the left atrial appendage. Can you go another time to the posterior aspect of the left superior, David, please?
Okay, just to see the gap.
This is the roof,
eh?
and you can see here
so
the gap that is at the superior aspect of the left superior pulmonary vein.
So this is the left superior pulmonary vein, and theoretically there should be a gap here. Okay.
Okay.
Perfect. Okay.
We are.
And if you go to the right,
we have placed now the lasso catheter in the right inferior pulmonary vein. So the posterior aspect is with a scarring, and if you look at the septal part of the right pulmonary veins, there is no scar, so there is a big gap, and probably we have to do a big line of ablation. This is very frequent, so Sorry?
Well, normally this is because since this patient was done before the contact force catheters, this area, it's always a low contact force, and it's not easy to have good contact here. So it's very often that you have the gaps in this anterior or septal aspect of the vein.
So
okay, go ahead, Antonio. Yeah.
This is also frequent. It's very frequent in patients in which the ablation technique was cryoablation. So come on to the posterior aspect of the inferior pulmonary vein. As the lasso catheter is here, I'm going to start doing ablation here.
In Hamburg, what we usually do is that we take an angiogram of the pulmonary veins and then mark the ostium based on the RO and LO view within the cartomap and then start burning. So I do see that you are not using angiograms. So do you know from the MRI that there is no PV stenosis, and do you know precisely where the ostium is? I mean, looking to the map, of course, the ostium could be everywhere. So is there any strategy that you could share with us, how you identify that you are outside of the pulmonary veins and that you are on the safe side? Yeah. What is the strategy that you are following if you do anterior and posterior lesions?
We usually
don't to go inside the vein.
We usually don't perform angiogram of the pulmonary veins. We look carefully at the image previous to the image we have previous to the ablation procedure. After that, we do a high-density map. And if the fusion is good, we are confident with that. So in this case, there is no pulmonary vein stenosis in any one of the 4 pulmonary veins. So.
But it's true that when we are using this MRI fused imaging, the quality of the fusion of the MRI is not as good. But in general, we work with MRI, and then if you have a good merge, the image is quite suitable. So we do not do that. Although I understand, and it's really something that gives you an extra safety, because then you are sure exactly where the ostium is located. Okay.
Okay.
Let's continue.
So I'm going to start to do the ablation. So I start here at the inferior aspect. Can you see the diagrams? Maybe we can.
A bit, yeah, maybe you can make it a bit larger, because I don't know if it's not easy to follow. This is the lasso. You see the signals here. The ablation catheter is up there. It's the yellow one, no?
Okay.
No, the blue one, sorry. And then we have in the green, we have the lasso signals. So there's some delay here already, but there's a complete signal pulmonary vein recording inside the vein, so it's not isolated at all.
So I do see, as Luis was pointing out, that you are using the contact force technology of this specific company. Is there any final goal that you are following? So what is the contact force that you would like to achieve, and what would you do if you cannot achieve it? Would you then increase the power? Can you give us some insights how you do the ablation? What is the strategy that you are following? How many watts? What the contact force and so forth?
You see here in the screen the contact force, eh? So you may know really what is the force that you are applying here.
We usually look for a minimum of 10 grams contact force.
And in case you cannot achieve it, because sometimes along the ridge it may be difficult to have a stable contact force, would you adapt the power then?
We sometimes do that. Yeah.
Can I ask the auditorium, please put your hands up. Who is using contact force during PV isolation? So it's not too many, but it's maybe 10%, maybe 15.
Yeah, I would say 20.
Okay, 20. Okay, so it's slowly penetrating.
No, but I think it's really a major step forward, because really sometimes you just burn and you're doing nothing, because you have. Another possibility is really to introduce an agilis, but the problem is that once you are started, if you want to change all the system, then sometimes it's hard. But in dilated atriums, we are starting to use the agilis as a first from the very beginning, because we know this anterior part is really difficult to reach.
Of course, we still miss a prospective randomized trial that is using contact force versus no contact force as a multi-center trial. There are some observational data that can show this. Maybe.
Okay, Antonio, we will connect with Hamburg for a while you keep on burning, and we reconnect afterwards to see the result. Okay?
Okay.
Okay. I think in Barcelona they have already isolated the vein. Is that the case, Antonio?
Yeah, we have.
Can you hear us?
Please, David, can you show the points where we have applied radiofrequency? So
you see that there's PV isolation here.
Okay. So we have done an anatomic approach guided by the tisular information about the scarring of the previous ablation. And you can look the points we have marked in the map where we have applied radiofrequency. So finally, go to posterior, please, David. finally, we have done the last application in the place where there was a small gap. Can you show, David? And here is where the vein was finally blocked. Cool.
So this is for the inferior vein.
Yeah.
But now you have the lasso in the superior vein, no?
Yeah.
But,
yeah. Now we have sign now. So maybe you want to see that the vein
can you show what the result was in the inferior? When you obtained the block, no?
Okay.
Is it already there or okay?
Yeah. No, I'm going to place the lasso catheter another time in the inferior one. So.
Can I ask you one question? I do see that you perform the reablation vein by vein. Was the original ablation also vein by vein, or was there a large circumferential lesion, and now you go into the carina for permanent isolation? What is the strategy that you usually follow in Barcelona? Is it vein by vein, or is it circumferential large area isolation?
Yeah, it depends on the kind of lesion you see on the MRI. If there is a wide circumference...
if you have a native case.
No, but Antonio, he's asking about the first ablation, and normally we do a large circle, and then after there's a large circle, but it's very often that we go to carina. But our first attempt is to the wide lesion around the veins. Huh?
Okay, David, do you want to pace? Do you want to pace into the...
We look also for the exit block, not only entrance block. So we normally pace from within the vein just to make sure that those tiny potentials are really far field potentials and are not involved in the vein. But so you already have completed this vein, and you plan now to go to the upper vein.
Show me, please. Move the map, please, to see that we are okay. Okay. Paste from inside. Okay. Try to capture. No, it's not blocked. So, okay.
Okay, so now what we are doing is just pacing inside the vein and seeing whether we have a block.
So
the problem is that
it's not blocked now. It was blocked, but there is a reconnection. So, okay.
Yeah, there's some tiny potentials here that probably represent there's some reconduction in some place. Okay, we may move again to Hamburg. Yeah. Okay, we will move to Hamburg. Still, you re-ablate all these points. Thank you.
Okay.
We will connect in a minute. Okay, Antonio? Hello?
Yes. Okay.
Can you hear me?
Yes, perfectly.
The proposal is that you just summarize a little bit what you have been doing while we were connecting to Hamburg. Can you just explain a little bit?
Yeah, we have already blocked the right pulmonary veins. David, show the lesion set, please. So this is what we had to do to block the superior one. And we are now mapping the inferior one. Okay, so the inferior one...
Which is interesting is that, just to say that, that really the extension of the area that, despite the first time we performed the ablation, the pulmonary veins were isolated, probably were due to edema. And then you recover, and when you do an MRI, you see that there's an extensive area where you really did not create a permanent lesion. So that is very interesting that you can see that on MRI.
Okay.
And now, please show us the result of the ablation if you want. Yeah.
Okay, we are now mapping the inferior, the left inferior pulmonary vein, and if you look at the lesion, the tissue lesion, you can realize that on the lateral aspect of the inferior one, there is a gap on the pixel intensity map, and if you can see the signal from the polygraph, there is a small signal in 9, 10, 11, 12, and it seems that this is the location where the gap is located. David has marked now in the lasso catheter the 9, 10, 7, 8, and 9, 10. I'm going
to... You mean the electrogram is entering... I cannot see it very well. Can you show us exactly the image and the MRI, where you think there is the gap there? Because in another projection, here, okay.
I'm positioning...
Yeah.
Okay. I'm positioning the ablation catheter here
really
in this...
A very small gap on the MRI, apparently, but it's
there
enough to create the...
There is a very small gap.
Conduction inside the vein.
Okay. I'm doing an application just here. If I'm able to place the catheter at this position. Okay.
So can I just ask the audience again, put your hands up, who is using MRI-based reconnection analysis? So after an ablation, you can have a patient that comes back with a recurrence. Is somebody in the room using an MRI to identify the site of gap and to see whether the lesion is complete? If yes, please put your hands up.
Okay.
I can't see anybody.
No, there's nobody, because probably you need a very...
There's a lot of work that needs to be done, Luis.
No, I think the problem here is to make this software available, no? Yes. And this is a very challenging thing that we have to do. Yes, tell me.
I want to show you that. Okay. David, turn a little bit more to the left, the map. Okay, so I'm just place the catheter at the ablation line gap we have identified with the MRI, and if you are able to look at the EGRAM that we are registering with the ablation catheter has a very small far field component from the left atrium out of the vein, and
you have to make it bigger. I cannot see it. Can you make it bigger, because we hardly can see it?
David,
make it as big as you can.
As they are looking at the screen on the left, please increase the gain.
Okay, there we see it now.
Can you see now?
No, we see it now.
Yeah. We see the ablation catheter now.
This is the EGRAM we are registering with the ablation catheter just at the place where the gap is located. Okay, so I'm going to do an application here. Okay.
Really a fractionated electrogram, eh? Let's see.
Okay, there is a delay on the signal from the lasso catheter.
Can you increase also the lasso catheter, because we have two screens, and we probably with one we will do, and we will see larger, no?
Yeah. Yeah, you have a split screen too, right? Maybe we
just need one of the two screens on the recording system, and then we can see the electrograms better. And now it's gone, no? Okay.
Okay.
Has disappeared?
Yep. So
I just there was a component here. If you can show us, but
we have blocked the vein.
Antonio, it will be interesting to have just one screen here, because we see two screens, and then we see the electrograms very small. So if you just can project one single screen of the recording system.
Okay, please, one single screen with the...
Go back, yes.
Okay.
And then go back and show the moment when you get the block there. With a single application, it's really fantastic that you can see in the MRI just such a tiny corridor, let's say, that allows conduction. And I think it's very illustrative of what you can really see when you have this.
David, can you show the moment where the vein is blocked, please?
I see that Antonio is putting some pressure on David. Yeah. David is our engineer, so.
David, they cannot see the review screen.
That is the difference between a doctor and an engineer. You know, the engineer is always relaxed. He has no patient in front of him.
Well, but
I do understand this.
No, but they are. It's more than an engineer and a doctor. They are a couple, a stable couple. It's like a marriage. So probably there are some even marriage conflicts.
That makes it even
the
worse.
right one. Can you show the right one?
Okay, so I I think we could see it here, but we are having the screen just in front of us. The best really would be you take the splitting off and show one big screen.
Exactly.
Okay, great.
Exactly.
And now go back to the time when you achieve
you
block.
can show that, yeah.
Can you show the right screen of the...
Yeah, but just to show the moment when we get the block, because I think that the signal inside the vein was really very delayed.
Yes.
And this is another point, whether this low signal is able to sustain AF, because this is another thing. Sometimes you may have conduction, but it's so delayed that maybe it's not able to...
Can you see now?
Tachycardia.
Yes.
Okay.
Yeah, exactly.
So this is, Luis.
Yes, we can see.
This is the moment when we block the vein.
Yeah,
okay.
Exactly. Yeah. You see these potentials, and then it's
so
perfect.
Maybe David, it could be nice, David, to show the E-grant just before starting doing the application.
Yeah, we have seen that. This was this very
okay, not necessary.
Yeah, you show it.
So
okay.
I go for the left superior. Okay.
Okay.
Okay, maybe we take time again and let's go back to Hamburg.
Okay, we'll connect to Hamburg and come back to you.
Okay.
Can you hear me?
Yes. Okay, we
have you already finished with the job here?
Yeah, we have finished. We have blocked the left superior. David, show the lesion set. Okay, we have closed the gap we had identified with the MRI, and we have checked for conduction block. Maybe David, can you show in the screen like the last time?
You
okay,
have to make it. Okay.
I'm going to now. Yes, can you see?
No, we see nothing. No, now we have it. Yeah.
Okay.
So this is spacing from inside the vein.
Yeah.
With no capture. And but
yes, it seems. Yeah. There is Luis. There is capture in 13-14, small electrogram.
Local capture. But
okay, so there is local capture with no conduction to the atrium. So at the end,
there's an exit block.
Yeah. So.
And can you show us the places where you have burn here in the superior vein, the left superior?
Okay, David, show please the carto. Can you show the cartos? Okay.
And so the electrograms before the ablation.
Yeah. There is the lesion set.
See that in the MRI, you see that there was really a gap here according to the MRI. So all this region was not really burned. And so by going here and applying only and selectively in this area, then you achieve the block of the vein. So that's really very interesting to see how good is the correlation between the imaging and the electrograms. And so I think you are done here. So it's really in 1 hour procedure, very short with limited MRI with limited points application. You achieve the block of the vein. So I think I have to congratulate you because I think it's been a very nice procedure.
We have done 11 minutes radiofrequency application.
And how much X-ray do you have done so far?
Sorry?
What's the X-ray time?
What was the X-ray? 9 minutes.
You have it there?
9 minutes.
9 minutes to do all the...
Including the transeptal access and all of that.
Yeah.
Okay.
And so now the 4 veins are okay. Are you happy with the result?
Yes.
You consider that it is finished now?
Yes. Yes, because the patient only had AF episodes. If the patient would have had left atrial flutter, maybe we can decide to do a line because David, show the posterior wall. It seems that there could be a corridor in between the both ablation lesion sets on the first procedure. But as the recurrences were always like AF, I'm thinking that maybe it's not necessary.
Exactly. Because one tricky business, as Professor Cook has said at the beginning, it depends on your scaling of the red. So you can make it everything red or everything pink, so it's a compromise. It's not exactly. So
but
it's something that have to be treated carefully, because you can discover or uncover corridors depending on the thresholds that you choose, and this is really in a very experimental phase, I would say. So that's why we should work to define.
So in our experience,
cheese actually.
So
I have a couple of questions for you at this point in time. First of all, I'm impressed how relaxed the Barcelona team is. I mean, there was a lot of criticism over the last couple of months with the Barcelona team, but I've seen the Barcelona team sitting there. I'm convinced that you are doing fine.
Confident with Neymar, you know.
Thank you.
It's unbelievable. So if I see the Hamburg team, it's heavily under pressure, but the Barcelona team is doing very well. So congratulations, first of all.
Okay, thank you, Dr.
Second question.
Okay.
Second question. This big red area, can you record potentials from this area? Did you map the area so that we know whether that area is isolated? And if you would put a catheter in the middle of this area, can you base the rest of the left atrium? Or is it a completely electrically isolated area?
Yes, but first of all, I want to show you the voltage map. Please, David.
But maybe you can try and show that when you put the catheter there, there's some signal there. And
I'm going to try. I'm going to try.
Capture, so it's not really a complete isolation of the posterior wall.
So
it looks like an isolated posterior wall, and it would be interesting, I think, also for the audience to understand that there are that it's not. And,
David,
and
please
imaging, of course,
show.
You have to define, as we discussed, the borders, the thresholds.
David, please show the signal from the polygraph.
Voltage, and this is MRI. So you can have an idea that probably is not really completely blocked. Yeah.
Okay, so it's just on the area of border zone. Okay.
Where are you with your catheter now? Can you put
just on the middle of the posterior wall?
Yeah. Can you project the cart also at the same time?
Perfect.
Yeah,
that's good. Now
so there's electrogram here. It's not isolated.
Yes.
The posterior wall.
Okay.
Okay.
But there's some fractionation around.
So my second question would be, with the analysis that you have done now, would you base the heart now to see whether you could induce an atrial tachycardia? Is this part of a protocol that you follow after the re-isolation, or is more or less this what you do? Re-isolation, no further pacing. And what about adenosine? Are you giving adenosine at the end of the procedure to see whether there would be reconduction that you could provoke?
We usually don't use adenosine to look for reconduction after its administration. We are starting a protocol to see if it is really necessary, but we usually, in a regular way, we don't use. So, with respect to try to induce any left atrial flutter or atrial tachycardia, we only do that if the patient has any recording with a left atrial flutter. But in this case, all the recurrences are AF. So I think it is not necessary. But if you want, we can try. No problem for that.
No.
I just want to understand the philosophy, because I mean I'm arguing also always with our American colleagues, because in America it's very common now to give isoproterenol in very high doses to see whether you get extra PVI triggers that you could ablate. We're also not doing this. So I would also, at this point in time, if there is no documentation of a clinical atrial tachycardia, we would stop. And we would also not give isoprol or any other drug to provoke arrhythmia. So it's following my personal strategy and my personal belief, but I just want to understand whether that is fine with the audience. So let's ask the audience, who would stop also at this point in time? So there's a guy who had re-isolation of the pulmonary veins. Okay, so let's put it the other way around. Who would not stop at this point in time? So I think there are very few people. So can one of you go to the microphone, please, and let us know what you would do in addition and why you would do it?
Hi, I'm Serge Trinias from Leiden, the Netherlands. Maybe I misunderstood, but in the first procedure you also did a posterior wall isolation or not?
No.
And in that case, I would re-isolate it.
No.
So let us answer Louis that.
No, what is striking is that in the first procedure, we thought we just do PV isolation. But if you look, it's not a line. When you think you do an isolation, you also do a large ablation of the posterior wall. So that's real life. But we are conservative in that sense that when you start pacing now and you don't know what you induce, we will have any clinical significance. So I really would prefer to go again 1 year later because of flutter than prolong the procedure for 2 or 3 more hours chasing something that you don't know whether it has clinical relevance. And I think in relation to adenosine, it is probably more important to make sure that you create good lesions with the contact, know that we have the contact, than to give adenosine, because the problem is that the edema is there and you may have also blocked even with adenosine, but then the lesion is not permanent. So I think what will make a big difference is make sure that with your contact you are creating a good lesion, and that probably is more important.
Okay, I think there is one more question, and then we have to go back to Hamburg. Please identify yourself and
John Kalman in Melbourne. I'm also very impressed with how relaxed you are, and wonder what you're drinking in Barcelona. But
smoking.
It was really just an extension of what's been discussed already. Do you think some of this is pre-existing? Is there something about the patient, hypertension, whatever, that, or is this really all the result of original ablation? The other thing is, it seems to me on the right, I may be incorrect, but anterior to the right pulmonary veins, it looks like there's almost no scar at all from the first procedure. Can you tell? Do you know something about what the contact was? Why it looks like that? Why there seems to be so little scar from previously isolated veins?
Yeah. This is something we see very often. I mean, even with a cryoballoon, that you discover that you have not created lesions. So I think we isolate because of edema, but we do not create permanent lesions in many of our lesions. And since the first case was done without contact, this is one of the explanations. Sometimes you really do not have good contact. Regarding the second question, whether this is an old existing scar, I think since you escalate the intensity according to the most intense gadolinium captation, and when you have a previous scar that is induced by the radio frequency, it's so intense that it really hidden previous pre-existing fibrosis, because pre-existing fibrosis normally is less intense. So I would bet that this was really created by the ablation in itself. Pre-existing, if you want to see it, you have to look in a different way, because the intensity is much more intense, the gadolinium captation, when you see this re-ablation than the original fibrosis in general.
Okay, I think that we have to move back to Hamburg, so it's time to thank our friends in Barcelona. I think you are done, and again, it was very impressive. We thank you a lot for this nice demonstration on the potential value of this MRI-based assessment of reconduction. Congratulations to a great case. Thanks a lot, and you get a big applause here from Athens.
Thank you.
Yes, and
thank you, and see you this afternoon.
You have another case.
Yeah.
Yes.
Okay.
Don't forget
see you
have
this
another
afternoon.
Case in a couple of hours.
So we'll come back to you. So relax a little bit, and let's see how the team is doing in Hamburg. Meanwhile,
okay.
Let's go back to Hamburg.
Bye.
Thank you very much to Barcelona.
Bye.